entitled Lymphoma 101, Understanding Your Tests and Procedures. And so we welcome Dr. Sarah Perry, who's a colleague of mine and hematologist in Calgary, to give us this presentation. That'll be about various tests, procedures, scans involved throughout the lymphoma diagnosis, treatment, and follow-up. It will provide some basic information and overview of these tests and procedures, map out some timelines and expectations, and inform on when certain tests are required or not required. So to introduce Dr. Sarah Perry, she's a clinical assistant professor at the University of Calgary, obtained her medical degree from the University of Calgary, and also completed her internal medicine and hematology residencies in Calgary, and then went on to complete a lymphoma fellowship at the BC Cancer in Vancouver. And so thank you, Dr. Perry, for taking time today to present on this topic for everyone. We look forward to your presentation.
Thank you. I just want to confirm that everyone can hear me okay? If not, I will go ahead.
I can, Sarah.
Perfect. Okay, excellent. So thank you, Dr. Stewart. So again, today, this presentation is just supposed to give an overview of all of the tests and procedures that we do, which I understand are quite a few and can definitely be a bit difficult to navigate. I think the format is that we'll go through the presentation, and if you do have any questions, we'll just kind of save them to the end and then discuss at that point in time. So as you guys are all well aware, there are many types of tests, but we have a reason for doing all of these tests. The first and foremost is to make an accurate diagnosis. The other thing is to understand the stage of your disease or the extent of disease. We also, sometimes when we're making plans about the best treatment, need to know how other organs are working, because sometimes our treatments can affect other organs. And then ultimately, some of these tests also help us to make decisions about what treatment would be best for your specific type of lymphoma. So I just have a couple slides up front just to make sure that we're all kind of starting off on the same page. So when I meet my patients, I kind of give them this definition of lymphoma. So lymphoma is a cancer of the immune system, where lymphocytes, that are a type of your white blood cells, divide more than they're supposed to. And these extra cells can sometimes form lumps if they go into lymph nodes or if they go into other organs. And sometimes we can also see these extra lymphoma cells, floating around in the blood or hiding inside your bone marrow. Lymphoma is not a single diagnosis. So there's more than 70 different types of lymphoma, which is again why there's so many tests to try and pinpoint the exact subtype that our patients have. And as you are probably aware, we usually divide lymphomas into two groups, non-Hodgkin and Hodgkin lymphoma. Hodgkin lymphoma is a unique diagnosis, and really all of the other types of lymphomas fall into the non-Hodgkin group. It's important to understand that all of these different types of lymphomas behave differently. So there's some lymphomas that we say are indolent, which means that they are very slow growing. And there's some lymphomas that come on very quickly and act aggressively and are more fast growing. So all of these 70 types of lymphomas fall somewhere along this spectrum. The other thing that I'll talk about in this talk is trying to figure out the stage. And so just again, to review quickly, the stage means how many areas of your body the lymphoma is in. If it's just in one spot, we call it a stage 1. If it's in 2 spots, but they're on the same side as the diaphragm, they're a stage 2. If there's lymph nodes above the diaphragm, but also below, it's a stage 3. And then anytime lymphomas go into an organ that's not a lymph node, we automatically call that a stage 4. One thing that I also always tell my patients is that since lymphoma is a cancer of the immune system, and your immune system is everywhere in your body, it's not uncommon that we do see it in many places. And a stage 3 or 4 lymphoma often means something different to us than, let's say, a stage 3 or 4 pancreatic cancer or lung cancer. Again, the reason why we need to know the type and the stage is because the treatment that we'll offer, the prognosis, and the chance of cure depend on all of those things. So briefly, the outline of this talk is just to go over the kind of the key things that we do when we're working up or managing lymphoma. We'll do a history, a physical exam, lots of blood tests, often some biopsies. We will order some special tests on those as well. And then there's lots of different ways to take pictures or images of the body, and then some other specific things. So now I'm just going to go through kind of one by one what each of these different things mean. So history. So when we talk about history, it's not the history of lymphoma in general and how it came to be. The history is really the patient's history. And that's a discussion between us and our patients to understand what their symptoms are and what their background is. So when we talk about a patient history, if it's kind of a new diagnosis of lymphoma, we like to know kind of what happened, when you first noticed a lymph node, what other symptoms you were feeling, what the time frame was for all of that. Some lymphomas have some risk factors that were associated with them. So we're going to ask things about, certain infections, if you've ever gotten treatments for other medical issues in the past, because sometimes that can also help us understand your lymphoma a little bit more. We'll always ask about other medical problems, again, because sometimes that will help us to decide treatment options that are safe for you and that are best kind of when dealing with other issues at the same time. Sometimes we can see a genetic component to some diseases, and so we'll ask if anyone in your family has ever had problems with lymphoma or other blood cancers as well. We'll often review your medications, again, because sometimes some of our treatments can interfere with that, or sometimes that can affect what we choose for treatment. And then if you are getting treatment, as you know, you will often meet with your hematologist before every cycle to review how things went, to review some of the side effects, and to discuss the plan moving forward. Often we can actually gain quite a bit of information from this. So for example, if somebody told me that they had a very tiny lymph node that's been there for 2 years and is maybe growing a little bit more, but they otherwise feel very well, versus someone who tells me that they have a big lymph node in their neck that came on 2 weeks and has tripled in size and now they feel like they can't breathe, already just that one sentence gives me a lot of information about how I'm going to move forward. On top of a history, we always do a physical exam as well. And so a physical exam is when we examine the body. In lymphoma specifically, we often check for lymph nodes, so their size, their location. We often check the spleen because sometimes that can be big in certain lymphomas. And then again, we always check heart, lungs, skin, see if there's any rash, anything like that, because again, that can affect our treatment, and that can also affect if the lymphoma could be in other places as well. Again, like I said, usually after we do a history and a physical exam, either at the time of diagnosis, while we're monitoring lymphoma, or during treatment, we generally have a pretty good idea about what's going on. But there's often some other tests that give us some more precise information, fill in some of the gaps, and then also test how the other organs are working. So the big thing are blood tests. So these are kind of some of the common blood tests that we routinely do for most patients with lymphoma. A CBC, a complete blood count, some chemistry tests, searching for certain infections, and then measuring some protein levels. So the first one here, the complete blood count, so that measures the levels of hemoglobin, platelets, and white blood cells that are in your blood. And just a very quick science lesson. So as you are mostly probably aware, your bone marrow, which is the inside of your bones, that's the factory that makes all of these blood cells. So it makes red blood cells that carry the hemoglobin and oxygen to your body. It makes platelets, which are the cells that help prevent bleeding and bruising. And it makes white blood cells, again, whose normal job is to act as your immune system. The reason why we measure these levels, there's a couple of them. One is because sometimes if they're high or low, it can give us a sense of how well the bone marrow is working. Sometimes if things are low, for example, it might make us think perhaps that there could be some lymphoma in the bone marrow that's kind of preventing normal production of these cells if it's at the beginning. Sometimes our chemotherapies or our treatments can also affect these blood cells. So we like to monitor them during treatment to make sure that they're not changing drastically. And then the other reason is that sometimes if they are low, then we do need to help people through their treatment or after treatment with transfusions of blood or platelets. And so that's why this is a test that's done fairly frequently when you do have lymphoma. The other thing that we measure quite often are blood tests that we call chemistry tests. And so these are tests that monitor how your kidney and your liver are working. So the kidney is usually measured with something called a creatinine, and then we get a sense of how well the kidney is filtering things in the body. And then the liver produces quite a few different enzymes, which we often do as well. Electrolytes, so those are things like sodium, potassium, calcium. Those are things that can sometimes be seen abnormally with kind of active lymphoma or sometimes during treatment. So we like to keep an eye on that as well. And then the other thing that we monitor for most patients is something called a lactate dehydrogenase or LDH. This can be sometimes increased with certain patients with lymphoma. And sometimes if this is high at the time of diagnosis, we follow this through treatment. And if we see this decreasing, then that can sometimes be a good prognostic sign. Sometimes, just as a warning, it can stay a little bit high and it can fluctuate a little bit during treatment. So I don't want people to panic about that because there are other things that can affect the LDH level as well. But it is sometimes kind of a crude test that we can see to get a feeling of how things are going. The other thing that we often monitor on blood tests are exposure or previous kind of immunity to different infections or viruses. So there are some infections that can be associated with lymphoma. And so if you have a type of lymphoma that we know is associated with a specific infection, sometimes we'll test for that infection. The other thing is that if people have infections and we give them treatment that suppresses their immune system, sometimes if they did have a virus, it can flare with treatment. So usually prior to treatment, we check things like hepatitis B and hepatitis C, again, to know if we need to watch that or manage that if we are going to give something that suppresses the immune system. And sometimes we'll check HIV on patients because it can be associated with some lymphomas. This one here is a little bit more complicated. So the other thing that sometimes we measure are protein levels that are called immunoglobulins. So if you remember back to the definition of lymphoma, lymphocytes, again, are the lymphoma cells that cause lymphoma. But in their normal job, when they're not causing problems, their normal job is to make antibodies. So sometimes certain lymphomas can increase the production of some extra antibodies that are called immunoglobulins. And sometimes if there's too much extra protein, that can cause a little bit of problems. So again, this is usually associated with certain types of lymphomas. And so if you have a type that we know causes some extra protein, sometimes we'll measure that up front. And if it's high, that will be something that will follow throughout your treatment. The other thing is that sometimes treatment can decrease both good and bad immunoglobulins or antibodies. And sometimes that can increase a risk of infection. So if people are starting to get a lot of infections after chemo, sometimes we'll check these protein levels just to kind of see where these numbers are at. But this is not something that we do on everybody, and it depends, again, specifically on the type of lymphoma that you have. So those are the main blood tests. The other thing that most patients get are a biopsy of some sort. And a biopsy is essentially a sample of tissue that pathologists, which are doctors that are trained at looking at these microscopic samples, look at under the microscope. And we can take biopsies from most places, but the most common ones that we do in lymphoma are either from a lymph node that's big or abnormal, an organ that looks like it has involvement of the lymphoma, or the bone marrow. Often at the time of diagnosis, we'll do a biopsy of one of these things because, again, we need to know exactly what we're dealing with, and we can only do that by having tissue of that abnormal lymphoma for us to confirm. Other times where we sometimes do biopsies is if we suspect that the lymphoma has come back after we've treated it, or if we think that it's maybe changed from one type to another. Again, so we have confirmation of what exactly we're dealing with so that we can plan the best treatment. This is what a biopsy of a lymph node looks like under the microscope. So I just added this picture in here so that you guys can acknowledge how difficult this can be sometimes for the pathologists. Lymphoma cells are those tiny, tiny little purple cells. And so the pathologists zoom in very, very, very close because obviously you can see from far away, it's hard to really make out what's going on there. And when they zoom in, they look at the size of the lymphoma cell, they look at the shape of it, and then sometimes they can do other special tests that we'll talk about in a couple slides here, looking at certain proteins on the surface of the lymphoma cell and some genetic or molecular markers. There are a lot of different ways to do a biopsy, and they vary on how much tissue they provide to the pathologist to actually look at under the microscope. So a needle biopsy provides the least amount of tissue for the pathologist, whereas something called an excisional biopsy, which I'll review in a second, gives them the most amount of tissue. And then there's one type in the middle called incisional. So there are two types of biopsies that you can do through a needle. The first type is called a fine needle aspiration. This is a very tiny needle that's kind of attached to a syringe, and they poke it into the abnormal tissue. So either the lymph node or if there's a mass somewhere else, and they try and suck out some cells through a syringe. As you can imagine, if you're kind of trying to suck up all these little tiny cells through a tiny needle, you often don't really get a very good sample. And so most of the time in lymphoma, this will not give us enough information to accurately diagnose it. The other way you can do a needle biopsy is something called a core needle biopsy. And so here the needle is a little bit bigger, and it essentially takes a core of the abnormal tissue. So this gives us a little bit more tissue, and more often we can make a diagnosis of it, but not always. So sometimes parts of lymph nodes or organs have lymphoma in it, and sometimes next to it there's none. So if you're just taking a little sample, again, you can sometimes miss it. So this also doesn't always give us a diagnosis. Incisional or excisional biopsies are done by a surgeon. Usually these do not require things like general anesthetic or staying for a prolonged time in the hospital. But essentially what they'll do is they'll cut out a part of the lymph node or the tumor. If they cut out just a small part of it, it's called an incisional biopsy. But if they take out the whole lymph node or tumor, then that's called an excisional biopsy. And these ones, because they take out more of the involved organ or lymph node, usually gives us the answer that we're looking for. And these are what most pathologists really hope that we send them when we're asking them for a diagnosis. The other thing that we sometimes do a biopsy of is the bone marrow. So as I explained previously, again, the bone marrow is the factory that makes all of your blood cells. And so sometimes these extra lymphoma cells will go into the bone marrow and take up space. And again, sometimes that can cause problems with other blood counts being low. And the biopsy of the bone marrow helps us to determine the stage of lymphoma. So again, as I said before, whenever lymphoma is in an organ other than a lymph node, we automatically call that a stage 4. So if the bone marrow does have involvement, that obviously tells us that a patient has stage 4 disease. And so sometimes that's helpful when we're planning our treatment decisions. So again, a bone marrow is often done to kind of complete the staging of our patients with slow growing or indolent lymphomas. For certain fast growing or aggressive lymphomas, we also will do a bone marrow biopsy, but not for all of them. And then sometimes if your blood counts are low or they're not recovering after treatment and things just seem a little bit out of keeping, we'll do another bone marrow biopsy then, just again to check and see what's going on in the factory that's making these cells. As you may or may not know, there are 2 parts to a bone marrow biopsy. So a bone marrow biopsy, I often tell patients, and you guys can agree or disagree, but I think is not as bad as most people think it's going to be. So it usually takes about 10 to 15 minutes. It's done in a usual room. And what we do is we take a little sample from the hip bone after we clean it to make sure that everything is sterile and reduce the risk of infection. And then we put some freezing or numbing onto the skin and onto the top of the bone. So a bone marrow biopsy should actually not be painful, but there will be a little bit of pressure that's associated with it. And there's 2 parts of a bone marrow biopsy. So the first part is called an aspirate, and that's where we use a small needle to take a little bit of the liquid bone out from the bone marrow. And so we pull that back with a syringe. Sometimes the bone marrow aspirate can be a little bit uncomfortable, but usually from start to finish, it takes maybe about 10 to 20 seconds. So usually that part is pretty short-lived. And then the other part of a bone marrow biopsy is an actual biopsy of the bone and the bone marrow. And so this is a little bit of a larger needle, which takes a core similar to the core needle biopsy, and that provides some more tissue for the pathologist to look at under the microscope. Another test that we sometimes do for lymphoma, which is not done for everybody, is something called a lumbar puncture or a spinal tap. So again, sometimes some lymphomas can go to the brain or to the cerebrospinal fluid that surrounds the brain. And that's an important thing for us to know because again, that helps us guide our treatment to make sure that we are giving treatments that will go into that area. Lumbar puncture can be done in a couple different ways. Sometimes we do it with our patients lying down. Sometimes we have them sit up on the bed. And similar to the bone marrow biopsy, the skin is cleaned and we put some numbing onto the top of the skin. And this needle is very tiny and it just goes in through the space between the vertebrae of your spine into the canal where your spinal fluid is. And then the fluid drips out of our tiny needle and then we can send that to the lab to get analyzed to see if there are any lymphoma cells there. Again, this is not done for everybody. It's only done if your specific type of lymphoma is likely to involve the brain, or if you're having any symptoms that suggest that your lymphoma may have gone to the brain so that we can check. Next, there are a couple of special tests that we do, and some of these can be a little bit confusing, so I hope I kind of broke it down to make a bit of sense. So again, all of those tests are helping us to figure out the exact kind of lymphoma, figure out where it is, but there are some special tests that confirm the lymphoma, help us with the prognosis because not all lymphomas behave the same way, and then also help us to decide what treatment you'll best respond to. one test that you might hear your doctor talk about is something called flow cytometry. And so, as I mentioned before, lymphocytes and lymphoma cells have certain proteins that are on the outside of the cell. And each lymphoma kind of has a unique footprint or unique set of proteins that are on the surface of the cell. And so flow cytometry, what it does is it takes a sample, it can either be from the blood or from the bone marrow, and it gives certain dyes that are associated with certain antibodies that bind to those specific proteins. And so based on what antibodies bind to the cell and the way that they refract light through, going through this machine here called a flow cytometer, it gives us a sense of what proteins are on the outside of the lymphoma cell and can help us figure out exactly what category or type of lymphoma that you might have. Immunohistochemistry is something that is similar, but this is where instead of kind of a liquid that's going through a cell one by one through the flow cytometer, it's using special dyes to look at how things stain on a biopsy sample. So again, I just added in this picture here so that you can see what the pathologists are dealing with. So it's these very, very minuscule little cells. And basically what they do is they do dyes for specific proteins that could be on the surface of your lymphoma cell. And based on which cells take up uptake of those dyes, it again helps us to figure out what the type of lymphoma is. So for example, you can see in this square, everything's purple, but here the dye would stain everything brown. So we can see that these cells here took up the dye. And so again, based on what they take up or don't take up, it gives us a sense of the type of lymphoma. The other tests that we do sometimes are tests that look at chromosomes. So normal human cells have 23 pairs of chromosomes, and certain lymphomas have abnormalities in those chromosomes, which can help us figure out the exact type of lymphoma. So sometimes lymphomas have too many, sometimes they have too few chromosomes. Sometimes they delete certain portions of their chromosome. So if you look at it, just a portion of it is totally missing. Or sometimes they do funny things where an arm from one chromosome switches to another one, and that's called a translocation. So there's a couple tests for chromosomes. One is called cytogenetics. And that's where, again, you look very up close at the chromosomes in a person, and you look to see how many there are. So again, that tells you if there's some that are extra or some that are missing. And then you can also visually see if part of one is missing or if part of one has maybe switched somewhere else. So here on this picture, you can see chromosome 14 and chromosome 11. And here they look pretty normal. So this one's kind of the pale blue purple. This one's a bit dark. And you can see here, they've actually done a little switch. So the bottom of one went to another one and the bottom of this guy went over here. And so we call that a translocation. Another way to look for these things is something called FISH. And that uses fluorescent dyes that attaches to specific genes or part of the chromosome. And so what we see under the microscope with that is that certain things glow, and the areas in which things glow, we can tell if they're in their normal spot or if they've actually gone and moved somewhere where they're not supposed to. Another test that we do is something called a molecular test. And so these are tests that are very sensitive, looking for DNA changes or gene changes. Certain lymphomas have certain genes or mutations that are associated with them. And so this is how we test that. And the other thing is that sometimes these molecular tests can help us to determine if there's a lymphoma clone, which means kind of one type of lymphoma cell that's dividing more than it's supposed to. Because again, you can have normal lymphocytes as well. And if you have a mix of normal lymphocytes, that could be normal, but if there's one certain type that's dividing and dividing and dividing, then that tells us that there's something abnormal. So that's kind of clonality. So those are some special tests in a nutshell. I have a couple more slides here. I hope I'm not boring you too much. So the next thing that we often do are different imaging tests. And so essentially there's many ways to take pictures of the body. And different types of pictures are better at seeing certain areas. Different types of tests are better at being more precise about measuring how big or how small something is. And then some of our images tell us how active a certain area is. And so the types of imaging that you'll get will again depend on many factors. So there's not a cookie cutter approach to every type of lymphoma, but the type that you have, whether or not you need treatment or we're just keeping an eye on things, time points in your treatment, those will all affect the types of tests that we'll order. So often we'll do imaging tests to determine, again, the stage, so where the lymphoma is. We'll do some images to see if you're responding to treatment sometimes, so if areas of disease are shrinking or not. If we're worried or you're worried that the lymphoma has come back, we might do some imaging tests to look to see if there are areas that are bigger or lymph nodes that are abnormal. And again, similar to the blood test, we often like to look at other organs to make sure that everything is working well as well. So the first kind of common test that you guys might have heard about or might have had done is a chest X-ray. So this is not used for staging lymphoma. So chest X-rays are good at giving us kind of a one-dimension picture, and sometimes they can hint that there is an abnormality that's there. They're not very specific. They don't give us things in 2 dimensions or 3 dimensions, only kind of side to side. And so they're not as specific or accurate as some other tests. Sometimes, but not always, some doctors will use this after treatment if the original spot where your lymphoma was diagnosed was in the chest. Sometimes we'll do chest X-rays just to kind of get a crude sense of if things look normal, but this is not routinely done, I would say. An ultrasound is another common test that we don't use to stage lymphoma, but it is good for measuring the size of lymph nodes that are close to the surface. It's not great at seeing lymph nodes that are deeper inside the body. So sometimes we'll use an ultrasound to either confirm that there is an abnormal lymph node, and also sometimes to guide a biopsy of that lymph node, again, if it's close to the surface. A CT scan is another type of test that we use. So on the left here, this is an image of a CT scan. And on the right here is the type of picture that it gives us. And so this picture here is showing us this very large abnormal thing on the side of the body here, which is a lymph node. And so as you can see, compared to the chest X-ray, it gives us a lot more details. So these are cross-sectional pictures and they're combined to make a 3D image. CT scans are done quickly and they give us precise measurements about the size of lymph nodes, the size of the spleen, size of other masses. And often for lymphoma, since again, it can show up anywhere, we'll do scans from the neck all the way down to the pelvis. Usually we'll do a CT scan at diagnosis, again, to get the stage of the lymphoma and figure out if it's on one side or 2 sides of the diaphragm, if there's any other abnormal organs. Sometimes if you have a type of lymphoma that we don't need to treat right away, then we'll use scans to monitor the size of those lymph nodes to see if they're changing. Often this is done every year or couple years, again, depending on the type of lymphoma, but it's not something that we would do, every month or every couple weeks to keep an eye on it. Sometimes mid-treatment, we'll do another CT scan, again, to make sure that the lymph nodes are shrinking or responding to what we're giving you. And then often we'll do a scan at the end of treatment to make sure that there has been a response, and then that can also serve as a baseline moving forward if we need to compare in the future. Finally, if kind of at some point in time after treatment, you're having some new symptoms that we think may or may not be related to lymphoma, sometimes we'll do a CT scan then, again, just to see if there's anything that's new or that's changed. A PET scan is another type of imaging that we do sometimes for lymphoma. So as you can see, the PET scanner picture here looks pretty similar to the CT. but the pictures that it gives us are very different. So on the right here, you can see the picture of a chest, and you can see this one area here that's glowing. So a PET scan uses this radioactive sugar dye to show areas in the body that are active. And so they can be active from cancer, they could be active because of infection, they could be active because of inflammation. So it can't differentiate between those things, but it does give us a sense for lymphomas how active they are. These scans take a little bit longer than a CT scan, so usually about 45 minutes to 2 hours. So PET scans, again, are not used for all types of lymphomas. They are done for Hodgkin lymphoma, and they are done usually for aggressive lymphomas. Again, as I said, so areas that are very active will take up the dye. And so if you have a slow-growing lymphoma, then it's not very, very active because it's not dividing very quickly. And so it won't usually take up a lot of dye. And so often for slow-growing lymphomas, it doesn't always give us a lot of extra information, and it doesn't affect what we would do for treatment. So usually in most slow-growing lymphomas, we don't do a PET scan. Some other times where we might consider doing a PET scan, so sometimes lymphomas that are slow-growing or indolent can transform into an aggressive lymphoma. And so sometimes in those situations, we might do a PET scan to look again at the uptake. Sometimes if it looks like the lymphoma is just in one spot, for some types of lymphomas, we can consider doing radiation to just one spot. And so sometimes a PET scan will help us to confirm that there actually isn't anything anywhere else. Sometimes if there's very, very small areas that we're worried might be a lymphoma, then we might consider a PET scan even if things look normal on the CT. And then sometimes at the end of tissue, if there is something abnormal on a CT scan, then the PET scan can help us to determine if that's a lymphoma or if that's just scar tissue. Next, MRI. So MRIs are usually good at looking at the brain and the spinal cord for lymphoma. Again, we don't do this routinely on people, only if you have lymphoma that's been diagnosed in the brain to follow, or you're having some symptoms that make us worry that the lymphoma could have gone to the brain. So that's something, again, not routinely done for everybody. And this is just a picture of a brain here with kind of a big circle here, which is abnormal. Okay, we're almost at the end here. So there are sometimes some other tests that we do, and these tests are usually done if you're going to get certain treatments or chemotherapy drugs that could affect the heart or the lungs. So there's some heart tests that check to see how well the heart is pumping. So sometimes certain treatments can affect how well the heart pumps, and so we like to know beforehand if there's any problem with the heart so that we can either adjust the type of treatment that we're going to use or adjust the dose of it. So there's one called an echocardiogram, which is an ultrasound of the heart that shows the chambers and the valves and checks to make sure it's pumping properly. And there's something called a MUGA scan that makes a video image of the heart to check whether it's pumping blood properly. And so different centers do different tests to check the heart. They both work well. And sometimes we'll get a cardiologist or a heart doctor to help advise what would be best as well. There is a type of lung test that we do sometimes, again, if we know that we're planning on treating with a chemotherapy drug that might affect breathing. And so it's called a pulmonary function test. This is a test where you breathe into a tube and it measures things like how fast you can blow the air out, how much you blow, and your oxygen levels to give us a sense of how well the lungs are working. Sometimes, depending on your specific circumstance, other tests might be done, but that hopefully was a broad overview of kind of the most common things that you might encounter. So that's all I had for you now. So I think I'll open it up in case there are any questions.
Thanks very much, Sarah. That was an excellent, comprehensive overview. A lot to go over, but thank you very much.
No problem.
We do have a few questions for you.
Okay.
One actually, I guess, relates to the cause of lymphoma. So one question was, has there been any research on the relationship between allergies and the development of lymphoma? So,
Oh, that's an interesting question. So a lot of times I would say we don't have a clear cause or a clear trigger for lymphoma. There are certain things that we do know. So again, there's certain infections that we know can kind of contribute to the development of lymphoma. We do know that sometimes if there are other underlying problems with the immune system, that can predispose to lymphoma. For allergies specifically, I'd say that's not an area that has a ton of research. So I don't know of any kind of specific allergy being associated with lymphoma.
yeah, fair enough. Sometimes we're seeing some new biologic treatments for things like even eczema. And so I've seen some people develop lymphoma after therapy for some of these things, which is interesting. A second question relates to a blood test for low immunoglobulin levels. So after treatment, if somebody's noticed to have low immunoglobulin levels, I guess two questions. One is, can they increase back to normal on their own? And the second question is, how successful is antibody replacement therapy to prevent infection?
Yeah, so those are very good questions, and a lot of people ask us about that. So often, once treatment is over and we're not giving treatment that's targeting the white blood cells, we do see that over time, those do get better on their own. That said, it can sometimes take months to a year for that to happen. And so it's not something that happens quickly, but usually they will improve. In terms of replacement, so we do have some criteria about when we consider giving people extra immunoglobulins. And really, it's if those levels are low and people are getting recurrent infections. So if they're just a bit low and we notice it, but people are otherwise fine, then we usually keep an eye on it. But if they're low and people are starting to get a lot of infections that aren't responding to antibiotics, that maybe need to be admitted to the hospital and things just aren't getting better, for those kind of severe cases, then we do sometimes use immunoglobulins to replace them.
Good. So then some questions about the workup test for lymphoma. So one question is, what if the lymph nodes were not swollen, but the lymphoma was growing quickly and was aggressive? So I think maybe the question is, does lymphoma always have to involve lymph nodes? And if it doesn't, how does that affect the tests that are required?
Yeah, so that's a good question too. So sometimes there can be lymphoma in lymph nodes and they're not super big, but I would say that with the caveat that if it was a very aggressive lymphoma, then you should see that a lymph node is changing in size or growing. Again, as I said, since it is a cancer of the immune system and your immune system is everywhere, sometimes lymphoma won't go into lymph nodes, but instead will go into the lungs or go into the kidneys. And our approach to that is, again, to get a sample of whatever organ looks like it might be involved with the lymphoma, again with a biopsy, so that we can confirm.
Great, thanks. And I think we've had three questions related to the risks of, I guess, radiation exposure associated with CT or PET. So these questions are, kind of what is the risk? Is there a limit to the number of CT scans a person should have in their lifetime? Is there any difference between PET scans and CT scans? These sorts.
So those are also very good questions. And so those are always things that we balance as well when we're trying to decide how many tests to order. I would say that our scans over the years have also become a bit more sophisticated in the amount of radiation that CT scans, for example, give off. These days, maybe compared to the past, can be a little bit less. I would say that most of us as lymphoma doctors do really try to think about kind of when we're ordering tests and if we need to order CT scans and if it's going to change what we do. And I'd say often the scans that we do order are because that they're going to advise us in some way about how we're going to change things. So I would say we don't order them if we don't think it's going to be important to the treatment. But the reasons when we do order it, it's because it will kind of help to make a big decision about things. I'd say when we're balancing the risk of radiation from a scan versus making treatment decisions, perhaps about a lymphoma that could be life-threatening, again, we need to balance that. And so again, we wouldn't be doing anything that we think would cause a lot of harm. The reason why we order them is to try and do things that will help and improve our plans and our diagnoses.
Okay, a couple questions about body parts.
Okay.
Lymphoma can occur anywhere. Why aren't
Yeah.
the legs scanned? So why aren't legs scanned?
Okay. So I'd say we don't have a ton of lymph nodes in the legs, and the legs are usually quite skinny. So sometimes people can get lymphoma on the skin of the legs or on the bones of the legs, but usually, of course, if there's something on the skin, we could see it. And usually the legs and the arms are kind of skinny enough that if there was a big bump somewhere, we could feel it. And if we were suspicious that there was lymphoma in a limb, then we would include that into our scans. But I'd say those are definitely more rare areas where it could show up.
Right. And then the second body part question is the brain. So do you need an MRI or can a CT scan determine if there's spread to the brain?
So these are also very good questions. So CT scans can sometimes help us. MRIs for imaging the brain are often more specific, and they can help us look at more specific areas of the brain. So if there was a big tumor inside the brain, we could definitely see that on a CT scan, but the MRIs just give us more information and help to kind of sometimes see lymphoma cells that maybe aren't inside the brain, but in the fluid outside the brain. So it definitely does give us more information.
And follow up, what are the symptoms to indicate the lymphoma might have gone to the brain?
Okay, these are good questions. So usually I'd say it's pretty obvious. For example, I've had some patients who have a droop to the side of their face, who are having seizures, who aren't able to talk or speak or move limbs. So usually it's not something subtle. Usually there's things that have kind of changed dramatically that help us to know that. Sometimes things like confusion, so maybe less obvious than obviously if you're having seizures, but if people are suddenly confused, not remembering certain things that they used to before, those are sometimes some of the symptoms that suggest that there might be lymphoma in the brain.
Okay, lots of good questions here. So does the increased presence of basal cell cancers indicate a change in stage of lymphoma?
So if you have a basal cell, does that affect the lymphoma stage?
Yeah.
So no. So each cancer we stage separately. So it has to be the same type of cancer in different spots.
Okay. Any topical ingredients linked to lymphoma? Deodorants, face creams? Anything?
Oh, also a very good question. None that I know of off the top of my head. I remember doing a presentation on marginal zone lymphoma at one point, and there was a question about hair dye sometimes associated, but not common things like creams or deodorants or that kind of thing.
Okay. How will I know when the slow-moving CLL changes gears?
So again, I tell people it's usually very obvious. So some things on the history that we'll ask you about are fevers. If you're having drenching sweats at night to the point where you would wring out your clothes or your sheets. If you're all of a sudden just losing a lot of weight that you're not trying to. If you have a lymph node that was growing very slowly and then all of a sudden it's kind of out of control. So usually it's quite obvious if the slow growing lymphomas are changing into something more aggressive.
Okay. It's one interesting question. Do you know if there's any research related to diagnosing lymphoma earlier before it's full blown? For example, is there something wrong with the immune system for several years prior to finding CLL in the blood, or I suppose lymphoma in the body?
So I think that's a good question. I think we do know that problems with the immune system can affect the way that the body kind of does surveillance to make sure how well things are working. And so sometimes if there are underlying problems with the immune system, we think that that can predispose people to forming lymphomas. That said, for people who do have known immunodeficiencies or problems with the immune system, I think a lot of their doctors are aware of that risk, but there's not kind of routine CT scans or PET scans or things that we do to look for it. I don't know if that answered the question.
Another question. So after treatment, I think, for lymphoma, why would physicians watch a high MCV level?
Okay, so that also is a very good question. So Dr. Stewart's going to be talking to you about treatment, but I always tell people every time you get a type of chemotherapy whose goal is to kill a lymphoma or a leukemia or really any kind of cancer, sometimes there can be some other collateral damage as well. And so MCV is the size of the red blood cell, and there's a lot of reasons why a red blood cell might have a bigger size. Sometimes it's vitamin or nutritional deficiencies. Sometimes if it's the red blood cells are starting to divide more and there's more baby red blood cells because the baby red blood cells are bigger. So all those things can affect the size of the red blood cells. But sometimes there can be some damage to the bone marrow, the factory that makes these cells, and there's a disease called myelodysplasia, which means that there's red cells that perhaps look a little bit funny and can be a little bit bigger. And so sometimes after people have received chemotherapy, that's something that we would keep an eye on, also in the context of the other blood counts and what types of treatments they received and that kind of thing. The risk of that happening is quite small, but it is something that we think about and monitor.
Okay. Let's see. So one specific question, is there a clear link to glyphosate?
Oh, interesting. I have to say, I don't know any off the top of my head. I don't know that answer.
Yeah, that's a specific research one. Why did I not get a bone marrow test with stage 3 non-Hodgkin lymphoma?
So that's also a good question. So sometimes in different institutions or across the country, different places have different guidelines. Sometimes if it wasn't going to change the type of treatment that you get, perhaps your physician might have said, you know what, I'm going to treat this the same if it was a stage 3 or a stage 4. So I don't think that they need it. If you're crossing your T's and dotting your I's to complete the staging, then we often do it, but sometimes it doesn't change the treatment. And so sometimes if we can avoid a procedure for whatever reason, then we'll do that too.
And for aggressive diseases, diffuse large cell and Hodgkin's, if you had a PET scan, then it's generally considered you don't need the bone marrow biopsy because the PET's more sensitive than the bone marrow.
Exactly, yeah.
Is there a relationship between numerous skin tags and lymphoma?
So not necessarily. Again, if there are certain problems with the immune system, but if there's just skin tags, as far as I know, there's no link to any specific lymphoma.
Mm-hmm. Is there routine testing to monitor for Richter's transformation for people who have CLL?
CLL. So again, that's similar to, again, the slow growing lymphomas changing to the aggressive type. So Richter's transformation of CLL is when it changes, as you know, to a very aggressive type. So again, it's usually very obvious. So there's not routine tests that we do, but if when we're doing a history, someone says, again, my lymph nodes are growing, I feel terrible, and perhaps there's some changes on the blood work, then that would make us investigate it. But if everyone or if people are feeling well, then we won't do extra tests.
Okay, again, a specific question. So how about lymphoma and the eye? So there's, so I guess the question, should eye doctors routinely look for lymphoma, and should this test be routine if a person's been diagnosed with lymphoma? Should they have a ocular exam?
Yeah, so this is also a really good question. So again, certain types of lymphoma are more likely to involve the eye than other tests. I think most eye doctors do know that, again, some types can involve the eye. And so sometimes if there's abnormalities that aren't consistent with kind of the usual things that they see, often they will refer to a colleague or someone who does kind of more specialized eye lymphoma for further diagnosis. Sometimes if there's lymphoma in the brain, again, because of proximity, we know that sometimes that type of lymphoma can involve the eye. We'll do kind of screening tests to look for that. And sometimes there's kind of certain types of slow growing lymphomas that can involve the eye. So it really does depend on the specific type of lymphoma and its location. But as lymphoma doctors, we usually know when to look at it. And most eye doctors will kind of refer on to people who are more specialized in looking at that in the eye if they are suspicious.
Another question is about relapse. So if there was lymphoma in the lymph nodes at diagnosis, and then it, I guess, responded to the chemotherapy, and then relapses, does the relapse also come back in lymph nodes?
So that's a really good question. So sometimes, sometimes it can come back in the same lymph node. Sometimes it can come back in a different lymph node. Sometimes it can come back somewhere else. So it really has a lot of possibilities.
Mm-hmm. Is the watch and wait approach safe and an approach used everywhere in the world?
So very good question. So I think the short answer is that yes. So we wouldn't do it if it wasn't safe or we thought we were compromising people's care. There's been a lot of studies for slow growing lymphomas that have showed us over the years that if people are feeling totally well, that treating them up front versus treating them when the lymphoma is starting to cause symptoms or problems does not affect their survival in any way. And so that is why we do sometimes do the watch and wait approach. We also know, of course, if we do give people treatment when they're feeling great, that will probably cause some side effects, and they could be serious side effects too. And so again, we're always balancing the risks and the benefits. And our goal with treatment is to obviously help people feel better. So if people are feeling good and we're giving them something that's making them feel crummy, that's not really in keeping with the goals. And then again, as I just said, we do know that watching does not affect people's overall survival at all. And of course, if it did, then we would intervene sooner. In terms of over the world, so for some types of lymphomas, certain centers may give a type of treatment earlier. So that does potentially vary from center to center. But in those centers that do consider trying perhaps a sort of gentle treatment, it's not that it's mandatory. So sometimes they'll have discussions about watch and wait versus something maybe light. So there is some variation, but the bottom line is that kind of the observation, or we call it active surveillance, because we're still keeping a really close eye on things, doesn't cause any harm.
Great. So here's a COVID question.
Okay.
Somebody that's been in remission for 12 years with follicular lymphoma. The question is there more risk for serious illness with COVID than other people of a similar age who don't have a remote lymphoma history?
Yeah, so these are really good questions as well. So I think the bottom line is that if you're kind of 12 years out from treatment, your lymphoma is not active or causing problems, the increased risk compared to the average population is probably quite negligible. That said, I keep telling all my patients, of course, still being very careful, hand washing, social distancing, wearing a mask is always a good idea too.
Good. Is the course of CLL different depending on which lymph nodes are involved?
That's interesting.
So lymph nodes like in the chest compared to lymph nodes peripherally.
So no. So again, any lymph node can be involved. Any can kind of grow at whatever pace, but having a lymph node in the neck versus a lymph node in the groin usually doesn't make a difference.
Okay. Can lymphoma predispose you to autoimmune hepatitis?
Oh, that's an interesting question. I have not heard of a link between lymphoma and autoimmune hepatitis, no.
Yeah. And then the other way, is there a link between uveitis and lymphoma?
Interesting. So I don't think uveitis can cause lymphoma. Again, if there was lymphoma in the eye and some inflammation, perhaps the two could happen, at the same time. But I haven't heard of any specific link between kind of having uveitis once and then developing lymphoma.
Yeah. For environmental exposures, is there any evidence that pesticides or herbicides increase the risk of lymphoma?
So that is a good question. I think that there has been some research that has shown some links. I think the really difficult thing, though, is that, again, often lymphomas do show up out of the blue, and kind of confirming causality of perhaps being around a pesticide 20 years ago and then developing a lymphoma now. It's hard to, say that that was definitely the link. But there have been some research that do show that those things can be associated with some certain types of lymphoma.
Great. So a few more. You're doing great.
Okay.
Hang on, Sarah.
the only thing is I'm supposed to be doing a bone marrow biopsy in 5 minutes.
Yeah, no, we'll
So I
let
do
you
need
go
to
in 5 minutes.
Okay.
So you're setting the record for questions. So that's fantastic.
Uh-oh. Okay.
Participation.
Okay.
So are there any restrictions to things we can't do the day of or before? Certain tests, blood tests, CT scans, biopsies, so eating, drinking, that sort of stuff.
Yeah, so those are good questions. Most of our blood tests, you don't need to fast. Usually for the scans, the techs at the scanner will usually give you some information about, if you do need to fast or not. I do know specifically for PET scans, since it is a sugar dye, that we need to make sure you're not eating, sugary things. And there are sometimes special rules for people with diabetes and how to manage their sugars around that. But I'd say for the routine blood tests and that kind of stuff, often no.
Okay, maybe the last question. So it's a tough one.
Uh-oh.
And I could throw in my 2 bits too. So it relates to how long does this whole diagnosis process take? How has the pandemic impacted the diagnosis process? And what can patients do to help facilitate a quicker diagnosis?
Wow, that's actually a very insightful question. So I'd say in a perfect world, these things happen quickly, but of course we know that that's not always the case. I think for lymphoma specifically, again, if there is a high suspicion, really the best thing would be to get a good biopsy up front. So if someone wanted to do a little needle biopsy as a patient, if it were me, I'd say, no, I don't want a fine needle aspirate. I want to get a good piece of tissue so that I know what I'm dealing with and I don't have to keep going back for biopsies. So I think kind of selecting the best way to get a good biopsy early is a good step. I think, again, before you see a doctor, really thinking about your history and having details about how things are changing and how things are affected, because that again gives us a sense of urgency about how quickly things do need to move. I think making sure all of your doctors are talking to each other, which we usually do, and we usually send notes back and forth, but that's another thing. In terms of the pandemic, so definitely I think when things first started last spring and the operating rooms were shutting down and less biopsies were happening, that definitely did have an impact on diagnosis at that point in time. However, that said, for really aggressive cases or really severe cases, those things, and I think now things are also back to normal, those things would still proceed. So if there was someone, with a big lymph node in their neck because they couldn't breathe, that person would still come into hospital and they would be prioritized to get a biopsy. So again, kind of based on the symptoms and based on our feeling about it, if things are super urgent, that should move quickly.
Yeah, maybe I just add a little bit. It's question's near and dear to my heart. So in Alberta, we have this thing called the Cancer Strategic Clinical Network. And one of our priority areas is cancer diagnosis, because we do feel this is a big gap across the country, not just in Alberta. So there is no comprehensive cancer diagnosis program compared to other countries, actually, that do have this. And so lymphoma is a problem, and we're trying to create a provincial lymphoma diagnosis program. So just in case people from Alberta are worried from some things that they hear, so to try to facilitate this faster so that people don't end up in hospital, because right now about 1/3 of lymphoma patients are diagnosed after they're hospitalized. So it certainly would be nice to diagnose people before they're so sick that they have to be hospitalized. We're trying to create this program. Now, there actually is a prospective randomized research study comparing core needle biopsies to surgical biopsies. And the winner in that study clearly was the core needle biopsy. So it actually had a higher sensitivity for lymphoma diagnosis, was done much faster, caused a lot less trouble for people in the short term and long term. And can access more lymphoma sites easily than surgery if you think of chest and abdomen sites. So that's actually what we're creating as our default biopsy procedure. Obviously, everybody needs to be up to speed of how to do high quality core needle biopsies. So this is different than a fine needle aspirate that, as Sarah said, is quite useless to diagnose lymphoma, but a well-performed core needle biopsy can work very well across Alberta, and I think across the country, but we have data in Alberta that the pandemic has definitely slowed cancer diagnosis in general. And there are people in Alberta who would have been diagnosed with cancer last year who aren't diagnosed yet this year because of the pandemic and everything that's happened around it. So great questions, and I guess that the message is we recognize that this is a problem and we're working on it. So probably with that, we should call an end to the session and thank Sarah. That was fantastic. Your voice held up, so that's